Module 6 today. We will talk about consciousness, and we will talk about sleep and states or stages or phases of sleep and consciousness. Now, this is one of those weeks where we could spend hours and hours discussing the same topic because it's never really complete, it's never finished. And I also want to mention that there is a parallel course to Intro to Psychology that is called, indeed, Psychology of Consciousness. And it's a course that it's complex because, as I mentioned, there are multiple layers of investigations that we can use to discuss what consciousness is. So in this lecture, it will be probably an hour and a half long lecture. I will do my best to summarize the basic elements of theories and research on consciousness from a strictly psychological perspective, which of course will include some neurological perspectives on one side and philosophical perspectives on the other side. All right, so a few definitions to begin this lecture. What do we mean by consciousness? I would like to start from a very basic perspective so that we don't encounter a philosophical barrier in discussing this topic. Now, for a very basic perspective, we could say that consciousness, it's pretty much the same as perception or awareness. So let's just begin with these two terms that we utilize as a primary way to assess the consciousness problem, so to speak. So we will start with awareness, okay? Awareness, okay? And wakefulness. Now, some of you might remember some basic discussions we had in week 1 in regard to these two terms. And I mentioned the spiker box in that context, which is one of those very basic neurological research items that we can utilize to monitor the action potential of those spikes. And so we could also say that from a very basic philosophical perspective, being conscious, it's pretty much the same as being awake and perhaps alert, okay? So whether by awareness, we also include alertness, okay, or not, it really depends on what type of brain imaging or neurological research methodologies we want to utilize. And just to sum up what we discussed in week 2 and 3, some of the ways that we study the brain involve things such as MRIs or functional MRIs, okay? SPECT, okay? We mentioned transcranial magnetic stimulation, we mentioned CT scans, and we mentioned EEG, all right? So EEG will dominate in these parts of the semester in week 6, because with the electroencephalogram, we get a lot of information when it comes to sleep patterns, all right? So this would be probably a good place to start. Sleep patterns, right? And you might wonder, okay, so are we saying that sleep and consciousness are deeply related from a psychological perspective? The answer would be yes, full stop. In fact, most of the time when we teach consciousness in any Intro to Psychology courses, we teach consciousness, states of awareness, as well as sleep patterns, as well as sleep problems and issues. So sleepness on one side, the sleeping pattern on one side, and consciousness on the other side are pretty much two sides of the same coin. This week, again, I will utilize several slides. And of course, for the ones of you that are enrolled in the course, you'll be able to access the PowerPoint in Module 6. So please review that as a way to prepare for the quiz. But this will be the introductory part to the slides. So we mentioned sleeping patterns, we mentioned consciousness, and there are a few terms that I would like you to keep in mind. So first of all, the question might be, how do we know that we are awake? Well, we already discussed the role of the action potential, we discussed the role of neurotransmission, and we discussed the role of neurotransmitters, specifically for the way we perceive the world, that we perceive our emotions, that we perceive our mood, changes and swings, and the way we perform ourselves as part of nature in general. Now, this sounds very philosophical, but it's also very practical because we mentioned that neurotransmission has to do with chemistry on one side, has to do with electric charge on the other side, and it has to do with a biopsychosocial problem from a broader perspective in terms of how we define who we are. In other words, we are more or less of quote unquote ourselves, whether we are fully awake or not. So this represents another question, which is consciousness on a gradient or a scale, on a spectrum, or is something that we turn on and off? So the first thing that we want to keep in mind is that when we think about our wakeful state, we think about the circadian rhythm, okay? We will mention this in the slides as well, but for now, keep in mind that the circadian rhythm, okay, it's really our internal biological clock. The word itself, circadian, means approximately daylight, like a day, almost day, right? So circa, circa in Latin for almost, okay? Almost. And dia, or dies, day, okay? An Indo-European root, okay? So almost a day, which really means a 24-hour clock, an internal clock, okay? Now, intuitively, you know exactly what this means. We do exist on a 24-hour clock, as in we have a specific amount of time where we are awake and a specific amount of time where we are asleep. Now, these things vary with time, varies with age, it varies with lifestyle, it varies with the presence or absence of neurological disorders, physiological problems, psychological issues, so on and so forth. But there are some rules of thumb that seem to be quite consistent. For instance, as we will see in the slides, younger individuals tend to sleep more in the sense that they will go to bed late or relatively late and wake up late if they had a chance. As we grow older, we tend to go back earlier than when we were teenagers, but we also tend to wake up earlier. Other things that we might witness is that children need extra time to sleep because they need to recover. Adolescents as well, there's a lot of pruning, there's a lot of neurological function that occurs, there's a lot of neurogenesis and neuroplasticity that happens in the brain, especially in certain areas that are very fast in their development. Think about the prefrontal cortex. So they need more hours, more sleeping hours in comparison to people in their early 30s, for instance. And the opposite happens as we age. We might need less hours, but more consistent. So it's less likely that a person in her 60s or 70s will party until 3 a.m. in the morning just because of the way the circadian rhythm or biological clock works. On top of that, we might also have other types of clocks that are more socially constructed, as in job related. Our work schedule might be different. So if you work night shift, for instance, your entire body needs to adjust for the lack of structure that is biologically predetermined. Now, when I say biologically predetermined, it seems to be that there is an evolutionary component to the sleeping patterns. So for instance, if you think about the average person, if we want to put this on a little diagram here, we're not a high degree of precision, but just to give an example, right? So if on this diagram, okay, we write the hours of the day. For instance, let's start from midnight here, okay? Midnight, okay? Okay. And then here, 6, noon. Let me make it a little bigger here. We're not going to do it to scale because I don't have much room here. We'll do 3 p.m. We'll do a 6. And then we'll do, let's say, 8. Okay, it's not to scale, just to give an example, all right? When we put some time on this side here and we put, let's say, energy levels here, okay, energy really in a broader sense in terms of wakeful state, alertness, awakeness, so to speak, and the ability to engage in the activity, okay? we might think that our alertness level is quite low at midnight, okay? It's kind of is getting high at 6, okay? Increases at noon, then it kind of goes down around 3, goes up again, and then goes down here, okay? Now, again, this curve is not to scale, but it seems to indicate that on average, we tend to be more alert, okay, between this area and this area here, okay? And again, let's say here, all the way to here, okay? And then we have a rising phase, here, and an in-between phase here, and a descending phase down here. Now, this is intuitively correct, so to speak. Now, this might vary between 6, let's say, and 7 a.m. or 8 a.m. when you wake up in the morning, you're getting ready for college, university, your job, etc. You start a day, okay? So you may have breakfast, and then you're ready to go, and your energy level keeps increasing to a certain level, and then again, you might not be ready to go to bed between 3 p.m. and 7, let's say 7:15, 7:30 p.m. You're still awake. But then once you start to reach 8 p.m., 9 p.m., your body starts to get ready for what's going to be the rest and digest process. You will be starting to get ready for the night time, okay? So you might feel more relaxed, more tired, more prone to engage in less active endeavors in your day, as opposed to right here, late morning, where you're ready to exercise, you're ready to work, you're ready to study, and so on and so forth. Now, from the evolutionary perspective I mentioned earlier, one of the questions may be, well, it's understandable why, as the sun rises, so to speak, we rise as well. After all, we are part of nature. So if there is such thing as a evolutionary based biological clock, it makes sense that our body follows the rhythm of life itself, that our bodies follow the rhythm of the sun, of nature itself. So as the sun rises, we rise. As the sun sets, we set, so to speak. We get ready for bed. But then you might wonder, what about this part here? What about this area that doesn't seem to follow what nature dictates, so to speak? If I might do the opposite, because you might wonder, why is the sun so strong? Usually, now we're not talking about specific meridian, specific geographic location here, but on average, why is it that the sun is strong here and we might feel a little tired in the earliest part of the afternoon? Well, there are a variety of explanations for this. The first one might be that we might have a big meal here, a relatively big meal, okay? And keep in mind that many other cultures outside of the US, lunch might be even bigger than dinner. So this is the primary meal, even more than breakfast. And so you might think that perhaps it's due to a digestive process. You eat a little too much and you feel a bit tired as a result of that. So you might want to take another nap here. And that's precisely why a lot of people tend to take another stimulant around this time. So one in the morning and one's around this time. It can be coffee, for instance, or energy drinks, which I really strongly do not recommend. Another evolutionary biology argument for that is that in primordial times, the speculation goes that our ancestor might have had to protect themselves from the strong rays of the sun. It was too much heat exposure between noon and, let's say, 3 p.m. So they might have been more likely to take a nap, an early afternoon nap, in order to avoid that type of sun exposure, heat exposure. And also from the perspective of hunting, it might not have been the best time to go out in the forest and hunt for food at that time. Of course, this to some extent is scientific research and intellectual epistemological speculation, but it's also consistent with what's happening in some cultural aspects in those regions that are closer to the equator, where you do have the sixth hour according to the Roman Empire, right? The sixth hour, okay? In Latin is the hora sexta, right? Sexta or siesta, okay, where you need to take a break. And many shops and stores are closed at that time for the same reason. So in any case, we might experience that as well. It's also true that our body gets used to whatever substance or stimulant or depressant we put in. So if you tend to be overstimulated because you drink a lot of coffee, the more you drink, the more the body will crave. And we will discuss them when we will explore drugs and other influences to our circadian rhythm. So we will talk about basic pharmacology. We will talk about psychedelics. We'll talk about stimulants. We'll talk about opioids. We'll talk about depressants. So we'll talk about mood stabilizers, so on and so forth. So in any case, both the chemistry inside our body as well as the chemistry that we might add to the system itself will have an impact on the way the circadian rhythm works. So on top of that, you have this regular, so to speak, rhythm, but then you might have a social work-related rhythm that might not be consistent with this curve, okay? So you might find someone who works at night, okay? For instance, I will use my wife as an example. She is a medical surgical nurse, and she's been working night shift for many years. So her shift starts at 7:30 p.m. She has the evening round. So she is getting ready around here, okay? So in terms of the energy levels expected for her work, this is what happens. So around here, she's getting ready. She's go up here at midnight, right? And then, of course, when it's 6 a.m., she starts to getting ready for the end of the shift, okay? And then she goes to bed and she sleeps, all right? Now, of course, so you can already notice the discrepancy here, especially this area here, full discrepancy between what your body would like to do and experience and what, unfortunately, your body is forced to do due to the social circumstances and your work, okay? The other big difference, and we'll mark that in black, so it's a black marker here, is the fact that when things go up here, they go down the opposite way, okay? And the same thing here, etc. So quite a difference, right? With two main intersections that you can see here, okay? Again, at the beginning of the shift here, so let's call it 7:30 here and 7:30 antemeridian a.m. right here, okay? Now, you can train your body, of course, to work night shift, and it's usually easier if you're younger, okay? It's also easier if you've been doing that from two perspectives. One, for many years, so you can get used over time slowly to this new schedule, and two, if your schedule is regular enough. So for instance, if you work as a nurse, if you work night shift in general, and someone were to ask you what's the best schedule to work night shift, it's much better to have, for instance, 3 days a week or 4 days a week in which you always work night shift, and you take a big break 2 or 3 days, rather than working night shift one night, then you don't work the day after, or you work the princess shift, so to speak, those 4 hours, then you work night shift again, and then part of the days, and then night shift again, because you keep changing shifts, you keep changing your quote unquote social clock, and that really collides with your biological circadian rhythm. On top of that, you can't really fool your body too much. So what's going to happen is this: your body, when you're done with your shift, assuming that 7:30 a.m., you're done with your rounds, your morning rounds, you're getting ready, you leave the hospital, you're driving home. So in that half an hour that separates your shift from driving home, you might be getting ready to go to bed. And of course, there might be a problem if you have to drive long distances, because you might be more likely to fall asleep at the wheel. But if you reach home, hopefully, then you are so exhausted that you're ready to sleep. And so you can pretty much sleep for 3-4 hours, no problem, okay? However, once you reach like noon or 1 p.m., 1 p.m. here, then there is a clash of needs, okay? Put this in red. There's a clash of needs here where your current biological clock is exhausted by the fact that you work night shift, and yet your evolutionary biology-based general circadian rhythm wants to wake up because it's daytime. Okay? So you might have a few hours where there's these two competing needs, two competing pulls, push and pull in your body. And that's where a lot of people have hard time staying asleep. Okay? In fact, some people that might work night shift might decide to wake up a little earlier, so they will not sleep 6-7 hours here. They might take a break, okay? They might have a little meal, and they go to bed for another hour or two before the beginning of their shift. Now, this is something that if you work night shift, you will have to learn how to master yourself by trusting your body, by listening to your body. But in general, this is something that seems to be going against what the biological clock wants us to be. Now, this is an example, and of course you have this in-between area right here between, say, 2 p.m. and let's say maybe 5 p.m. or 5:30 p.m., okay, where, again, the competing needs are kind of getting aligned, and so this is where you might need to sleep more because you're tired, but you can sleep more because the body is not really willing to do that. So you have this between thing. On top of that, you might have another pattern, which that pattern has to do with either social or academic expectation, okay? Now, this is getting a little complicated here, but let's assume that our quote-unquote true circadian rhythm is the one in blue, so I'll make it a little thicker. Okay, so this is the circadian rhythm that occurs on average, the average person that does not work night shift. Okay, so I'm gonna make it a little bigger here so it's easier to see. All right, here we go. All right, so this is a big curve. Now, what happens if things change week by week or day by day, for instance? So Monday through Friday, you might have this schedule, and you have no problems adjusting to both your family needs, your social needs, your job needs, your academic needs, etc. But then on weekend, because you don't really want to waste your free time, you might do things slightly different. Okay, so you have no problem, let's say, between maybe, I don't know, 11 a.m., okay, 11 a.m. and let's say 6 p.m. Okay, so this part of the circadian rhythm is consistent, okay, but then it's Saturday night, and you want to go out and party, for instance. So you want to preserve some of extra energy, okay, so perhaps having a curve that's slightly like this, okay, a little high, so you see the discrepancy here, that's called this discrepancy here, delta, okay, this angle here, delta, and we continue from there, and you might want to do something like this, okay, you continue, okay, and then eventually you need to go to bed, but you might go to bed very late or in the early morning hours, I don't know, 4 a.m. That's when you go to bed, okay? And at this point, you're sleeping here, okay? But then you want to wake up, you're getting hungry, and you wake up here, something like that, okay? So this can be done if you're very young, this discrepancy, and of course you have the opposite minus delta here, okay, this angle here. But of course, it gets harder and harder if you don't get the chance to rest and digest. So very often, if you are young and you party all night, Friday night and Saturday night, then this Sunday should be really used to recover before you start a new routine on Monday. Another thing that has to do less with fun, so to speak, but more with needs and deeds, okay? Think about delayed gratification that we mentioned before, is whether you have yet another schedule, all right, where the pattern kind of looks the same here, okay? Let's say you have a big quiz, a big test Wednesday morning, okay? And then you stay up late in the evening and part of the night to study more. So this is similar, okay? Let's see that this is like 10 p.m., okay? But then you reach 1 a.m. and you're really exhausted. So at this point, let me use this red color here, you go to bed here, okay? And then you stay asleep, okay? Etc. Now, one of the reasons why I'm telling you this is, well, first of all, you need to learn how to trust your body and to listen to your body, all right? Your body knows best if your body has been given the chance to express itself, if your body has been the chance to really rest properly. And then the other question would be, okay, how many hours on average do we need to sleep if we are in our early 20s or late teens, okay? And the average answer varies, but I would say at least 7 full hours would be the optimal answer. If you can push through 8.5 hours, even better, right? But you need enough time to rest. Now, there are several theories associated to the sleeping patterns, which we'll discuss later in the slides, but just to give you some hints, well, first of all, you need to keep in mind the activation of the suprachiasmatic nucleus and the way it interacts with the circadian rhythm, especially in the production of melatonin on one side, which will allow you to fall asleep and stay asleep, but also the way the brain works in terms of recuperating the energy was lost during the day. You see we have different phases in our sleeping patterns. You have REM phase, so rapid eye movement phase, and then non-REM phases, and 1 and 2 and 3. And then these are constructed into patterns. So you go back and forth, you have these little spikes throughout the night. And then you will see that some of those patterns are associated with certain waves, delta waves, theta waves, etc. And some of them will make more or less relaxed. So there's still an activation at night. So some of the theories that we'll encounter say that sleeping is extremely important for biological balance. Okay, so from homeostatic processes. This is another term that I would like you to remember. Homeostasis, okay? Spelled differently depending on what textbook you use, but it really means to remain in balance, right? Homeostasis in Greek, okay? So the homeostatic process, so to recuperate, and it's very similar to what happens if you think about physical exercise between the catabolic and the anabolic effect, okay? So catabolic, and anabolic, right? Okay, right. So if you think about physical exercise. But there's also a variety of theories that consider sleep as a rehearsal based on and for what happens during daytime. So you might have this view of the sleeping pattern as a way that the brain utilizes to categorize all the experiences you might have had in the previous, let's say, 6 hours. So this might or might not include specific dreams that will be viewed as a rehearsal of what you previously experienced. And just as much as this is relevant to what we said last week about memory, those patterns can be associated, reconstructed in different ways. This is very different from certain psychoanalytic theories, for instance. Think about Sigmund Freud, that viewed dreams in a very different ways, not just as rehearsal, but also in the context of subconscious, unconscious, and preconscious needs, motives, and patterns. Okay, we'll see how that plays out. In any case, sleep is fundamental for biological and psychological health. Without sleep, we cannot function, period. In the next part of this lecture, we will also talk about the specific of sleep, and we will see how that plays a role in our psychological health. All right, let's start again by giving some general definition of the connection really between consciousness and sleep. So the first part, think of awareness, perception, wakefulness, states and phases, and sleep patterns. So this is one of the things that it's important to keep in mind. We will use this jargon, not really in a profoundly philosophical sense, but at the very least, in a general understanding. We will talk about issues and problems toward consciousness from a neurological and neurobiological perspective, which of course will influence our psychological state. So we'll talk about narcolepsy and cataplexy. We'll talk about insomnia, sleep apnea, night terrors, and sleepwalking, and many, many others. Let's continue with something that has been usually agreed upon in the general psychological sphere of investigation. So consciousness includes all the sensations, the perceptions, the memories, and the emotions a person is aware of at any moment. So in this sense, consciousness is synonymous with awareness from a psychological standpoint. It was further defined as waking consciousness, with more specific labels such as normal, clear, organized, alert, awareness. Okay. Now, there's an acronym that I would like you to remember when we study consciousness from the psychological perspective. It's the acronym of SUD. Now, I have an image here of Luca Cordero di Montezemolo, the former president of Ferrari in Italy, with a beautiful suit. So SUD stands for selectivity, unity, intentionality, and transience, SUIT. It's a very useful definition because it really combines the current research on consciousness from the perspective of neuroscience and psychology, and also defines the characters or characteristics of consciousness. So let's start to see them one by one. All right, as for selectivity, which has to do with filtering out what is not necessary for our understanding. So you are conscious if you pay a selective attention. You filter out irrelevant stuff. The classical example that is usually quoted in psychology is the cocktail party phenomenon. If you are at a party and you're having a conversation, which can be very, very interesting, and suddenly you hear your name, someone's calling your name, and you cannot help by turning around and see who was talking about you, even if they're not calling you directly, even if they're just mentioning your name and your last name, so you know they're talking about you. And it doesn't matter how interesting a conversation you're having, you are more likely to turn around and figure out what they're saying about you, either good or bad things about you, but it's something that it's really, really capturing your attention. This has also to do with the so-called dichotic listening, with plenty of research studies that focus on that, when you're asked to focus on two different things, one on the left ear and one on the right ear simultaneously, different modalities, different noises, different words, especially. You don't hear what you just heard in the right ear. You're not able to pay full selective attention. So selectivity has this ability to filter out irrelevant things that you might not find irrelevant, you might not find interesting for that specific task. Now, that also means that you have the ability to focus as if your attention was a DSLR camera, zooming in and zooming out. We mentioned this before when we talked about perception and memory. And there are plenty of studies that are really, really intriguing. And I will add those studies, those videos to this lecture in a separate video, however, because of copyright restrictions. And again, I would like you to watch them, but I really wouldn't like you to know too much about them, okay? One, it has to do with change blindness within selectivity, and the other one with inattentional blindness. So if you don't know these studies, please stop the video here, this one, and go there and watch these other two videos, because otherwise I'll give you the information. So do that, take some time, and resume this lecture when you watched those experiments. All right, if you're back, now I feel free to share the details with you. So the first study, it's a study by Simon Levin. It's a study on change blindness. It was a field experiments done in New York, in the city of Ithaca, New York. So their subjects were chosen at random on the Cornell University campus. And what the experimenter did, there was an experimenter, a Confederate, we say, right, posing as a tourist, who asked a person on campus for directions. Now, when the participants started giving directions, two other experimenters posing as construction workers passed by carrying a detached door. The construction worker passed between the experimenter who had asked for directions and the participant. Now, at this point, the two researchers, Simon Levin, had the first experimenter hide behind the door and exit the scene, while a second new experimenter, the same gender and age as the first one, replaced the first. So a new person now, right? Now the question was, the question that they posed it was, would the participant, the subject, notice that the person to whom he was giving direction had changed? I mean, you would think that this is obvious, right? If you were just talking to one person and this person was replaced by another one, of course you will notice the difference. Instead, the opposite turned out to be the case. The most obvious answer turned out to be wrong most of the time. So you really did not pay attention if you were in this experiment. You were not paying attention in terms of selectivity because you were asked to focus, subconsciously so, you might argue, to focus on the question itself, not on who was asking the question. Quite fascinating, this experiment by Simon Levine. Another one by Simon and Chabris was the experiment of inattentional blindness. So if you watch that, now I can share that the nickname for this experiment is the gorilla experiment. So it kind of gives away what happens during that experiment. I will not say more because I assume that you watched the video. But yet again, this has something to do with the way we pay attention. Okay, so specific things. So that was as for selectivity. To continue in our SUIT acronym, U for unity, which is the ability to bring everything together, especially if you, let's say you're reading a book or you're watching a movie, you're able to put all the different or multiple pieces into one single narrative. You're able to attach every single piece to a plot or to create a story that creates this unity yet again. So after that, there's I, intentionality, which really is the intention, the focus and attention, which can be either internal or external, to what you want. Okay, so this is fascinating because it really means that consciousness is also related to your goals, your motives, your overall motivation. And this really has a lot of philosophical and even theological undertones. If you're familiar with some elements of theology, when theologians refer to God wills into existence a specific item, a specific object, that's very, very close to the intentionality of consciousness. So if you want something to exist, you will it into existence. So you have the intention, you focus on a specific thing, right? So again, consciousness as awareness, but also consciousness as attention, as well as motivation. Finally, T for transience, which is pretty straightforward. Our consciousness is always on motion. It's always moving, right? You cannot, or you should not be able to focus on any single task all at once because you should be able to be flexible enough. You need to switch focus, just as a DSLR camera does. You can imagine from the perspective of evolutionary biology, our ancestors being forced to switch focus rapidly in case of a possible attack from an animal or something like that. So this is something that really helps understanding how consciousness can be characterized by suits of selectivity, unity, intentionality, and transience. Now, in the next slides, we also see there are different kinds of consciousness, some of which occur spontaneously, some are physiologically induced, and some are psychologically induced. Now, those are somewhat arbitrary divisions because according to the current state of affairs in science and the biopsychosocial model, all these things are overlapping magisteria. So it's not true that anything is only psychological or only physiological. It's more complex than that. So within the one that occurs spontaneously, daydreaming, drowsiness, or dreaming in general, and then we will see the definition more in detail between dreaming and night terrors and nightmares. Then you have some that are physiologically induced, hallucinations, orgasm, for instance, food or oxygen starvation. In the first case, we will discuss that even more in depth next week. We will talk about medications and drugs. The orgasmic response, of course, it's a combination of all the things we said about the nervous system and the endocrine system, and of course has a psychological component as well. And then when we think about oxygen starvation, it's a fascinating research into altered state of consciousness, ASC, as well as NDEs, near-death experiences, or out-of-body experiences. Very, very fascinating research. And finally, the psychologically induced sensory deprivation, hypnosis, and meditation, all of which we'll discuss in the next slides. Now, the following image really is more of a summary of some important scientists and researchers. I mentioned a few already, Simone Chabris and Simone Levine, but just a few names that I would like you to start to be familiar with. Dietrich Schönemann and David Berlinski are the ones portrayed here, but other famous researchers are Claudio Rizet, René Guénon, Giulio Tononi, Mario Beauregard, Christopher Chabris that we met already, Rupert Sheldrake, Daniel Simons, who we met already, and then Gerald Edelman. So again, at the connection between consciousness from a psychological perspective, as well as consciousness from a medical or neurobiological perspectives. All right. Now, in practice, when we think about consciousness, we think about sleep. We mentioned that multiple times. So on average, a person spends about a third of her life while asleep, okay? So a person who is lived to be 75 years old will have slept about 25 years. And a young person, let's say you as a student, a 20-ish year old person, you spend about 6 full years asleep, which is really, really interesting. And in this little image, you see hours of sleep and then the different phases. Now, I did not give you the full acronyms. So in yellow, you see the awake state, and then phase 1, which you can see it's stopping on the top right in REM, or rapid eye movement phase, right? And then non-REM means non-rapid eye movement phase, and 1, 2, 3, and 4, with the red part in the 24-hour clock awake, and then the sleeping patterns divided between REM and non-REM phase. So this is an overall view. And then you also see that there are specific parts of your sleeping pattern that involve dreaming activity. Okay, so dreams on the bottom in the kind of brownish maroon color. Okay, so that's where dream occur. We always dream, even if we do not remember. It's an important thing to keep in mind from a neurobiological perspective. All right, some neuro underpinnings, although we already mentioned that in week 3. First thing first, circadian rhythm, we mentioned that earlier today, which is modulated and generated by the SCN, or suprachiasmatic nucleus. If you do remember, we mentioned the optic chiasm before, and the pituitary gland, which is right there. And if you look at this picture, you should also remember the discussion on the limbic system, the epithalamus, hypothalamus, and thalamus, and the role that these parts of the brain plays in general. If you keep in mind the difference between what's in front and what's in the back, what's on top versus what's on the bottom, and also what's outside and versus what is inside from a neurobiological perspective. So what does the SCN do? It regulates the pineal gland secretion of the hormone melatonin. And of course, the fact that it's able to increase melatonin, this will produce drowsiness. So it's modulating more or less melatonin, more melatonin to make you feel drowsy and eventually fall asleep, and less melatonin if you want to wake up. There are 2 stages in sleep called hypnagogic and hypnopompic states that has to do with falling asleep right before you fall asleep in the first case and getting ready to wake up in the second case. And when we explore the theory of dreams, something that I mentioned in the past was that in antiquity, think about the ancient Romans, for instance, they were really relying on dreams to make decisions. It's an important decision, the decision of government, decision of wars, decision of the empire, based on what, for instance, the emperor dreamt of right before waking up, which is also something that's utilized in research. If you, for instance, want to be able to remember your dreams in a more specific, more precise way, what you should do as an experiment, you should set your alarm about 15 minutes before your usual wake state. If you wake up every day, I don't know, around 6:30, you should set up your alarm at 6:15 a.m. Because you'll be brought into full awareness directly from the REM phase. So your dreams will be more vivid and you'll be able to write it down more precisely. All right, let's continue. How do we study consciousness from the perspective of the sleep cycle? This is, again, a very brief summary. So part one here, EEG is the primary way to study it. Yes, we did discuss more detailed neuroimaging techniques such as fMRIs and SPECT, but from the perspective of sleep cycles, we are looking at waves. So it makes sense that we're using electroencephalograms, right? Because the EEG shows variation in what? In brain waves, okay? And that's how we can determine different stages of sleep. So you have 4 non-REM stages or phases and 1 REM. However, something to keep in mind is not progressive in a linear sequence. So during your sleeping time, 8-hour period average, people typically progress through all full 5 cycles, and each cycle lasts about 90 minutes, okay? And then we will see that this is, in the next slide, exemplified by different shapes of the wave itself. So on your left side, the EEG really helps us distinguish the awake state on top, the stage 1 non-REM phase, and one with theta waves. Okay, you can see those theta waves there. The stage 2 or N2 of the non-rapid eye movement state, you can see in the 2 boxes, the sleep spindle and the K complex on the right side. And finally, the stage 3 and 4, which is N3 usually, the non-rapid eye movement with delta waves. Okay, and finally, the 5th cycle with the REM phase. Okay, now on the right side, you see different colors here from red to green, the different types of waves in comparison to the Earth. So between 15 and 30 for beta, 9-14 alpha, 4 to 8 theta, and 1 to 3 delta, each of which has a very specific characteristic. So beta waves are associated with awake, normal, and conscious, fully conscious. Alpha with relaxed, calm, a meditative state or prayer state, creative state, visualization, imaginific state. Theta waves, deep relaxation and meditation, and problem solving. And we'll see how that plays into some other theories, including the psychoanalytic theories. And finally, delta, as you would expect, right? Deep but dreamless sleep, because again, dreams mostly occur during the REM phase. So to sum up, when the person is awake, her brain waves show a high frequency with low amplitude pattern. High frequency, low amplitude. See here, high frequency EEG with low amplitude. Okay, you would expect that just in intuitive terms. Now, during the REM phase, breathing and heart rate increase. This is where you dream. The non-REM phase is also called non-REM or N1, N2, N3, and involves different patterns of body relaxation. Of course, slower EEG activity and the heart rate and respiration are slower as well. All right. Non-REM brainwaves are of low amplitude and are fast with mixed frequencies. Brain activity changes with each state, and people become more difficult to awaken as they progress through the 4 stages of non-REM sleep. So let's see how that works. In the next slide, you see those, I don't know how to call it, Tetris, or I don't know, it looks like a Sumerian temple, a Maya temple here, Aztec perhaps, or a ziggurat. So you see that from the awake states, right, with all those nice waves, you go to REM, N1, N2, and N3, and then you stay there for a little while. You progress and you go up to N2, N1, and REM without being woken up again, unless someone wakes you up, of course. So you stay in the REM phase, then you drop down to N2, you stay there for a little while, you drop down to N3, and then you go back. Now, you see that between 3 and 4 hours of sleep, you might be reaching a wakeful state. For instance, if you are woken up and you need to use the restroom, for instance, right? And then you go and drop back to N1, N2, and so on and so forth. So you have different patterns, okay? And finally, after 7.5 hours of sleep on average, you stay there in N2 for a little long, and then you go back up and you are back to a wakeful state, fully conscious, okay? Now, yet again, we're not talking about philosophical terms now. By fully conscious, fully awake, we don't mean to interpret that in a philosophical, theological sense, but more in a strictly biological sense. All right, last part of the sleep cycle summary. So you have it all. We already mentioned that, but it's worth repeating that. Beta waves, small, fast waves associated with alertness and being awake, okay? Alpha waves, larger, slower waves associated with relaxation and just before falling asleep. Again, keep in mind the hypnagogic phase. Delta waves, very large and slow waves associated with a move to deeper sleep and a further loss of consciousness. So keep in mind this gradient. And finally, theta waves, they happen during the REM phase when you dream and have a frequency of 4 to 8 Hertz and are activated when we are being insightful, creative, or experiencing a healing process. This is very often referred to as the healing waves. You probably heard or watched some YouTube videos with ASMR noises and theta waves, subconscious relaxation, something like that. There are plenty on YouTube nowadays, and they mimic the musical spectrum, the frequency, that the theta waves have during the REM phase. Personally, I don't find them particularly relaxing, but that's just my opinion. I don't want to influence your judgment. All right, some theories and explanation of why things happen, all right? So some hypotheses, sleep can be viewed as an enhancer of memory storage. In other words, when we dream, we consolidate memories, right? Now, neural areas that are active during the learning of the test become active again during sleep. So it's like as if you were restarting a specific behavioral pattern or something you just learned. You're rehearsing. So sleep as rehearsal, okay? Performance on tests, this is interesting, usually improves if you test a person a day after he has learned the test, okay? This is connected to what we said about memory. When is the best time to study? There are a lot of factors. You might say, based on what we said earlier, when you look at the whiteboard, if you're awake, you just had your coffee, it's 10 a.m. in the morning, you're full of energy, you can study, and yet a lot of other things occur during the day that might be compromising what you're studying. So you could also study before you go into bed. So there's nothing in between what you study and when you have the exam, assuming you have an exam or a quiz the morning after, okay? Now, another feature is, of course, a dual track mind. So as if you have two parallel features that can exemplify the conscious state, right? So this is something that we use both in psychology as well as in cognitive psychology. So psychology in general, clinical psychology, but also in cognitive neuroscience. It's this dual tracks of information processing. Pretty much one that exists at the conscious level and the one that exists right below the conscious awareness, okay? So this is also connected to some analysis of subconscious and preconscious, all right? So one of the examples besides Freudian psychoanalysis might be something that is occurring as blind sight that we discussed during memory, right? We discussed that when we were talking about partial awareness last week, so you should remember that. All right, now let's continue with the second part. While dreaming occurs during all sleep stages, dreams in the REM phase tend to be longer, more vivid, and involve more detail and movement. So you have a rehearsal, but you might also argue that you have an enhanced rehearsal. In fact, you might not even be subject to Newtonian laws of physics. When you sleep, you can fly, you can jump, you can become a superhero. You're not limited in the same sense. So this is true from a neurobiological perspective, but you can also see how from a spiritual or spiritualistic perspective, claims that our soul leaves our body while asleep makes a lot of sense. You are not confined into the material domain of your body. And earlier we mentioned different types of consciousness, right? The one that are physiologically induced as opposed to spontaneous or psychological induced. And at the center of that slide, I believe was slide number 3, the center was orgasm. And orgasm, the orgasmic response, is very often in the literature, not just scientific literature, but also in the poetic literature, referred to as the little death, where we partially separate ourselves from ourselves and we melt into the other person, the orgasmic response, which is entirely consistent with this non-body confined perceptual modality. Also very fascinating when we think about philosophical as well as cognitive science perspectives such as embodied cognition. All right, the last point here, paralysis of muscle occurs so we cannot act out our dreams. Lack of muscle paralysis due to REM sleep is called REM behavioral disorder, which is connected, it's not the same, but it's connected to narcolepsy and cataplexy, which we'll analyze further. So you have this filter, this Vito filter, where in your spinal cord, if you remember what we said about efferent and afferent neural pathways, and the role that the somatosensory cortex and the motor cortex plays in our interaction with the world, you see how you're dreaming, for instance, of running away from someone chasing you, but you're not actually running away, right? You are able to live, or your body, your subconscious self is able to stop the afferent neuron from sending the signals to your limbs and moving them for real. Now, sometimes those things do happen. My father told me not a long time ago, actually, this past summer, that he was dreaming of playing soccer. He was a professional soccer player back in Italy, and he was dreaming of having a, I think it was a penalty kick, and it was right in front of the opponent, the team, and he was about to score this goal, except that he really hit the wall while asleep. So this paralysis of muscles doesn't always work. So it was kind of funny for him to remember this occurrence, although it was pretty painful at the time. All right, let's continue. We have about 28, 29 slides. So dreams and the groundbreaking discoveries of psychoanalysis. Now, we mentioned multiple studies in psychology. We talked a lot about memory and perception last week, and now those studies that I just mentioned to you, especially the most famous one by Simon Schubert, Simon and Levine, are very famous. And most people studying psychology will have heard of psychoanalysis of Sigmund Freud. Now, I put this meme here because Aquinas is not impressed. I always like to say this. Most of the things appear to be groundbreaking discoveries in psychology or neuroscience simply because we have a very short-term memory, pun fully intended. We forget that for the last 3,000-4,000 years, a lot of things that we know about ourselves were already well known in antiquity. Now, this does not mean that psychological and neuroscientific research is not needed, because we need to have solid empirical proof as well. But it's quite marvelous to find out that all of these ancient philosophers were right all along. Now, I mentioned Aquinas because I mentioned his name multiple times, and Aquinas is a relatively modern philosopher. We're talking about the Middle Ages. We're not talking about the ancient Rome, ancient Greece, or even ancient Sumer or Ur. But, I like to say that we should be impressed by the fact that we are still seeing the proof of all these theories. Albeit with some issues, there is indeed a replication crisis in psychological research, where some of the studies that I quoted here and are constantly cited in the scientific literature fail to be replicated in the way that the first experimenters thought them to be. So always look at the scientific research with a grain of salt. Trust the science, trust the process, but do your best to really untangle all the examination, all the analysis, especially meta-analysis when you do that. All right, so psychoanalysis means Sigmund Freud. Yes, Freud is not the only one, of course, okay? And he was definitely not the first person to utilize psychology, as we just mentioned. Psychology existed as a non-manifested field for the last 5,000 years. But psychoanalysis as a term is usually credited to him in these very specific ways, which is not analysis or psychological analysis, which really is the product of Jung, Carl Gustav Jung, who of course worked with Freud. But let's see what type of perspectives we have. One that is not necessarily Freudian. The first one is the REM-RRR, which is not a dog barking. It's just a way I came up with to define the rapid eye movement, rebound, restore, recovery perspective. Okay, I just like it to call it RRR. I don't usually like acronyms, but it's kind of fun to remember that as such. And it's this idea that you use sleep, especially the dream phase, the REM phase of sleep, to rebound, restore, and recover previously experienced things during daytime activity. Okay? There is an extra rapid eye movement sleep following REM sleep deprivation. There's some body of research that attempts to investigate whether we can change sleeping patterns by depriving ourselves sleep to enhance this or that aspect. I really not encourage you to try any of this. It's extremely dangerous, and the research results are, for lack of a better term, quite controversial and not clear at all. So there is not really good reason to deprive yourself of sleep. You cannot function without sleep. Now, going back to the core of our conversation here, to Freud, psychodynamic theory emphasizing internal conflicts, motives, and unconscious forces. Now, when we use unconscious, you might be also confused, because the term itself can be confusing. You have unconscious, subconscious, and preconscious. Preconscious simply means before consciousness, so that can be also utilized in a sequential or temporal way. Okay, preconscious as before you have consciousness. From a everyday, or rather every night perspective, the state upon which you will wake up, you're preconscious, okay? Or from a developmental stage, children as less conscious than adults, for instance, in the context of their ability to understand the world separated from themselves, okay? Object permanence, we will talk about Piaget quite in depth. But also, you could argue that unconscious and subconscious very often are used in as synonyms, okay? Something that is beyond the surface. If you study Freud, you're probably familiar with the image of this either a pyramid or even more famously, the iceberg, with the conscious self only really coming out of the surface in a very small percent, but the rest is really sunk or under the water, so it's unconscious. So, and this has to do, of course, with the Freudian perspective of ego, id, and superego, which we already discussed, but we will encounter again when we talked about psychotherapy. All right, some other elements of Freudian psychodynamic theory in the context of dream research. Wish fulfillment. The Freudian believed that many people dreams are expression of subconscious or unconscious desires. And so you have this manifest content versus latent content as you sleep. Okay, so you manifest outwardly something that you might not be fully aware, or maybe you don't want to be fully aware because you're repressing or suppressing things. Okay. Other important notions, dream symbols, images that have a deeper symbolic meaning. And then the activation synthesis hypothesis, according to which dream content may be affected by more commands in the brain that occur during sleep that are not carried out, which is connected to the previous slide we just mentioned. Okay, so you have this activation synthesis where the dream itself, it doesn't start with the content, but it's a result of something that's been previously modulated by the motor commands in the brain. Okay, so the content is a product of the motor command. Now, according to Freud, there are 4 dream processes which act as mental filters that really have the main purpose of hiding the true purpose of dreams. So you have condensation, displacement, symbolization, and secondary elaboration. Condensation It has to do with combining several people, objects, or events into a single dream image. Okay, think about what we said earlier about unity, right? Displacement, directing emotions or action towards safe or unimportant dream images. Symbolization, expressing feelings or ideas symbolically in dreams, so not literal expression. And finally, secondary elaboration, making a dream more logical and adding details while remembering it, which will be connected also to the memory issues and retrieval we mentioned last week. Now, we will switch gears a little bit here toward the end of this presentation. We will talk about hypnosis. Now, if you study psychology, you've probably seen a lot of either images or memes or videos or movies where you have these, psychotherapists or healer or hypnotist using either a pendulum or a pocket watch, just like the one I use in class, and have the subject, the person, the patient fall asleep and be completely deprived of free will, and they'll let them do whatever they want, whatever the hypnotist does. Now, this is really not true. Nobody can be forced to do things against their will, okay? So, and you could also argue that nobody can be forced to do things against basic Newtonian physics. I'd be willing to consider kind of non-Newtonian physics, quantum physics, but at the same time, a lot of these are mostly conspiracy theories. In modern science, I feel that the term quantum is just throughout when someone doesn't really understand quantum mechanics in the first place. It's kind of a God of the gaps argument. But in any case, it's not true that you can be made to do whatever the hypnotist wants if you're in a state of hypnosis. Simply not true. You might be more or less susceptible or suggestionable to the indication of hypnotist. So we'll see how that works. But what is hypnosis? Well, the term itself comes from a Greek term, hypnos, which simply means to sleep. And in the relatively recent history, this had to do with certain appreciation, especially in Europe, from certain esoteric, occult, and even Near or Far Eastern philosophies. Here I quoted the work by Franz Anton Mesmer, whom we encountered previously, a doctor / healer / Heilpraktiker / what we would refer to as nowadays as naturopath or naturopathic practitioner or naturopathic doctor, who is the inventor, we could say, of animal magnetism, this idea of the élan vital, this vital spirit or principle that flows through all animated beings. And if you remember, we mentioned this before, anima in Latin means soul. So not just the rational soul that we possess as human beings, according to the Aristotelian or Aquinas definition, but also animals and plants. Okay. Now, in practice, what happens during hypnosis? There are physiological changes. So there's a great advantage of left body parts. And in terms of gait, there's a tendency to go toward the right if a person is in hypnosis. Now, this might also have to do with very basic function at the level of the cerebellum, as well as the motor cortex, okay? But in terms of the way people might be less prone to exercise control, okay? There's also increased respiration rates, decreased heart rate, which is very, how can I say, it's consistent with any type of meditative or mindful practice, and then changes in cortical ERPs. Why do we use hypnosis? And can we use hypnosis? Should we use hypnosis? Well, in terms of what the research indicates, for the vast majority of cases, we cannot make a claim that hypnosis works for, memory, remembering patterns, but it does work to modulate and inhibit pain perception, okay? Classical example, because it's been studied quite in depth, labor and delivery pain, okay? And of course, when we're talking about hypnotherapy, there's also an application for habit control, especially in the context of addiction, smoking cessation, et cetera, et cetera. Quite interesting and quite useful. Okay? Now, why does it work? Well, you could say that hypnosis can also be viewed as placebo/nocebo effect. So how much you believe, you could say subconsciously so, or pre-consciously so, the person hypnotizing you, putting you to sleep. Yeah, keep in mind that hypnosis really means a deep state of relaxation or meditation. In fact, it's going to sleep as a word, to be put to sleep, okay, hypnosis. We have scales, the Stanford, the Harvard, and the Barber, and many others, but those are the ones that I like to discuss very briefly here. In the Stanford Hypnotic Susceptibility Scale, you have 3 forms. A and B emphasize compliance with motor-related suggestions, are parallel, permitting test, retest reliability. And then C emphasizes cognitive components of hypnotic susceptibility. The Harvard Group Scale of Hypnotic Susceptibility, it's administered in a group setting. The subjects score themselves, and it's less accurate than the previous one. Finally, the Barber Suggestibility Scale, it's like the Stanford test, it's performed on an individual basis, but it's rated by the examiner and consists of only 8 tasks. So this is how we monitor how susceptible the person is to the suggestion and the advice or the indication and direction of the hypnotist. Other theories and hypotheses: A, hypnotic age regression, false childhood versus past life memories. We talked about this last week. We talked about how difficult it is to fully trust what we remember. It's even more complicated if the person is under a lot of stress, or has been victim of any type of abuse, or it's a very, very young person from a developmental and neurodevelopmental, especially perspective, because children can also be made to believe in memories of facts that never occurred to them. Okay. Now, in some new age spiritualistic areas, hypnosis is used to stimulate age regression. Now, of course, from perspective of empirical science, it's hard to demonstrate the validity of such claims, and they also have to do with a specific theological and philosophical perspective. When we talk about age regression, we might mean one life, so going back to childhood memories, which will be not too different from really psychoanalytic perspective according to Freud, or even analytic philosophy according to Jung or Otto Rank. But it would also mean throughout ages, which really means throughout lives, and past life memories also means the belief in reincarnation. So just mention a few researchers here, and by researchers I mean serious researchers that did a lot of empirical studies. Some of them are MDs, some of them are PhDs, some of them both. And they work in neuroscience, neurobiology, medicine, and psychology. And they work on reincarnation, past life memories, hypnotic states, and NDEs, or OBEs. OBEs as out-of-body experiences, NDEs as near-death experiences. Ian Stevenson and Jim Tucker worked together. Ian Stevenson passed on, but he was one of the pioneers in these NDE studies in India. Raymond Moody, very famous, again, within the more new age literature, and I don't mean to discredit his research. I'm just saying that he's more of a popular name in that type of literature as opposed to clinical research. Ibn Alexander, you probably heard of him recently, or rather recently in the last 8 years, because of his experiences in regard to near-death perception. Ronald Tudor in regard to reincarnation in general from a more historical perspective. Thorvald Detlefsen from a more anthropological and mystical, we could say, perspective. Now, of course, this still might have to do with suggestion and the placebo nocebo effect. I suspend judgment. I simply want to present to you with the current state of affairs and what type of research is out there in hypnosis. Now, to be even more specific, what are ways to explain away hypnosis do we have? Well, we have the task motivation theory, according to which hypnosis is not an altered state of consciousness, but it's a predisposition in a normal state of awareness to attend to command suggestion from a hypnotist. Okay, so predisposition, it's in itself a complicated term because it might mean that we have something innate. Again, this has to do with the nature nurture debate. We're more predisposed to believe the suggestion of the hypnotist. Trance theory, and trance can be spelled either with a CE or with the S at the end. Trance will be with the S in Latin. Trance, it's a English borrowing from French, but it really means the same thing. So moving from one state to the next, that's what trance means, trance theory. Hypnosis involves a trance or mystical state, in this context we can say, during which the subject is in a heightened state of susceptibility to suggestion. Hidden observer, when asked to write down information, will often reveal information against what he or she has already said. Hypnotic suggestions lead to improvement in visual acuity in myopic or nearsighted subjects, and hypnotic deafness can affect auditory sensitivity and visual choice reaction time. So those are examples of how powerful suggestions are, whether they have some sort of altered state of consciousness or some other paranormal, parapsychological explanation or not, they work on the subject in specific situations. Okay, so it's quite interesting to research. We could spend an entire semester on hypnosis. So in this module, we'll stop right here. In the last part, however, of this lecture, I want to mention some problems, some issues connected to both consciousness and sleep. You have dysomnias and parasomnias, again, from the Latin term for somnium, right? And the problems are usually divided into two big categories. Again, some example, narcolepsy and cataplexy, insomnia, sleep apnea, night terrors, and sleepwalking. So let's talk about each of them really quick, and then I will let you go and review all the studies. So sleep deprivation, in general, the word is pretty straightforward, right? Being deprived of sleep. What does the research indicate? The research on total sleep deprivation with humans is not possible and is becoming more difficult with animal models due to bioethical consideration. As an example, rats totally deprived of sleep will die. So it makes sense, if you have some sense of morality and ethics, that we cannot, knowing what we know nowadays, play with, let me use the term, the souls of animals to see how much they will resist. And of course, physical death of an animal in a sleep deprivation study might or might not be directly linked to sleep deprivation in a causal sense, but of course we cannot take the risk, and of course we should not engage in this type of studies to let me use the term, prove what we already know to be true. So what else besides physical death is linked to sleep deprivation? It is linked to loss in ability to regulate body temperature and weight changes. And then you also have physiological sleep problems related to sleep, not necessarily to the deprivation of sleep, but attached to it. I just want to mention CIS because it's one of the most horrible sleep problems, the sudden infant death syndrome, also called crib death, which is, as the name implies, sudden unexplained death of a healthy infant. And of course, based on all the research, and I would say parental common sense, infants should sleep on back or on side to try to prevent SIDS. Now, night terrors, we'll see that night terrors are not the same as nightmares, okay? So what are night terrors? They are a sleep disorder in which a person experiences symptoms of a panic attack, okay? You might even have some extreme flashbacks as part of that, especially if you have PTSD or CPTSD, complex PTSD. Again, they're not nightmares, which occur in the REM phase, because nightmares, as the name implies, are mares during the night, and I really encourage you to find out the etymology. I'll not spend too much time on the nightmares here, but just as dreams that occur in REM phase, nightmares also occur there. But night terrors occur in non-REM sleep, usually stage 3 or 4. From a developmental perspective, children can usually be seen sitting upright in a state of sheer panic while experiencing night terror. They can scream, they breathe rapidly while appearing awake. And also for adults, the person is not fully conscious, okay? Non-REM, but not fully conscious. This disorder is most common in children between ages 3 and 8 and disappears as the child grows older. All right, let's talk about insomnia, which involves problems in going to sleep or maintaining sleep, and it's often associated with anxiety or depression. So there's a psychological component as well, okay? It's not only physiological. Sleepwalking or somnambulism, which is just a translation, occurs in non-REM sleep during stage 3 and 4. And you can also find a very specific type of somnambulism that has to do with talking rather than walking. And this is called sleep talking, which also occurs in non-REM. In terms of what the statistics say, about 10% of the population experience insomnia at times. They may sleep as much as a norm, but the quality of sleep tends to be poor without full rest and recovery. So you might sleep, but you not feel rested in the morning. What can we do about it? Well, psychotherapeutic and integrated treatment for insomnia include relaxation training, which of course has to do with basic ability to work in cooperation with your sympathetic nervous system, CBT, cognitive therapy, meditation, prayer, and hypnosis, even self-hypnosis. And there is a bit of a disagreement within the analysis of research in terms of how much a person can self-hypnotize. But as I mentioned earlier, hypnosis has to do with both etymologically and biomechanically with being put to sleep. You could say that hypnosis, yet again, is an enhanced type of meditation, or at the very least of relaxation. So you could self-relax in that sense. Think about strategies such as square breathing, or you can think of body scans or guided imagery and things like that. All right, so moving on, sleep apnea, which of course it's not the same as insomnia. Very often those two terms are confused. Sleep apnea has to do with the absence of pnea. Now, if you remember what we said etymologically about the Greek term of that's connected to pneuma, to respiration, to the soul, to the spirit, to the breath. A is the opposite, is the depriving that of pnea. So you should know that it has to do with some sort of breathing issue. So sleep apnea causes airflow into the lungs to stop for at least 15 seconds. And about 33% of the population, on average, this happens more with males and overweight subjects. They can have as many as 100 episodes of sleep apnea per night. People with sleep apnea get poor quality sleep, they feel extremely sleepy during the day, and may suffer from severe headaches or work-related accidents, as well as from memory loss. So it also accumulates over time. Furthermore, sleep apnea may lead to high blood pressure, heart disease, heart attack, and stroke. What can we do for sleep apnea? Similar to what we said earlier, psychotherapy plays a very important role, and so does exercise, because of what we said in regard to the average person experiencing that. So you can help body weight, body structure, body function. And then continuous positive airway pressure, or CPAP machines, can also help, and minor surgery can also be recommended. All right, we talked briefly about sleepwalking and sleep talking, focusing more on sleepwalking because it's the one that in the general literature people experience the most. It's characterized by walking or other activity while seemingly still asleep. I want to stress that it can also be other activity. So somnambulism does not only involve walking itself, but can also be other type of physical process. It's common in children 6 to 12 years old. It may occur at any age, and it appears to run in families. Now, with everything nature and nurture, it's really hard to pinpoint the percentage in causal terms of what is the primary origin or etiology of sleepwalking within families. But we see a strong correlation overall. It affects approximately 1% to 70% of children and is more frequently seen in boys. Of note, the incidence of sleepwalking decreases with age, which is always a good news. Common misconception, there is absolutely no danger in waking a sleepwalker. Nothing happens to you. This is more something that could help the plot of a thriller, a nice book or a movie, but it's not the truth. What about activation? Also, something that is not true. It's a false misconception. Sleepwalkers are not acting out a dream. Okay? I heard of this in certain areas of, I don't know, intersectionality between Freudian psychoanalysis and either theater therapy or some element of integrated methodologies to psychology. But in any case, this is not true. And we know this because the EEG brainwave activity of sleepwalkers indicated they are indeed in the sleep stage 4. So they're not acting out a dream. All right. The last slide is a bridge to other 2 videos I would like you to watch. Living in the Hic et Nunc. Hic et Nunc is Latin for here and now, living in the present moment. As usual, careful what you wish for. Would you like to live in the present moment? Maybe yes, maybe there are plenty of good reasons so that you don't ruminate about the past and you're not anxious about the future. Okay, we'll see how that plays a fundamental role in psychotherapy. And yet, there are very severe problems that really compromise the life of people that are forced, they're captive, they're prisoners of the present moment. 3 elements, 3 examples. One that has to do with what we said last week, amnesia, to do with memory, and the other 2, narcolepsy and cataplexy, which are connected more with consciousness and sleep states, although there is plenty of overlapping elements here. So let's analyze the term first. I will not review amnesia because we talked about that last week. We talked about anterograde and retrograde amnesia specifically. And we talked about Korsakoff syndrome, so there's no need to review that. I'll encourage you to rewatch the video of week 5, if you don't remember, which is interesting since we talk about memory. But let's talk about narcolepsy and cataplexy. So narcolepsy involves falling asleep suddenly and unexpectedly. As the name implies, narco has to do with narcos or narcissus, the Greek myth, and if you are familiar with Greek mythology, you should be familiar with that the specular image in the surface of the lake, okay, which of course is connected to narcissism as well as the flower. You know, narcissus is a beautiful flower, and of course with the act of fading away in sleep. Okay, so on one side you have narcolepsy, okay, and then on the other side you have hypnosis, so narcissus and then hypnosis. Anyway, you fall asleep suddenly and unexpectedly, excessive daytime sleepiness, and abnormal, extremely abnormal REM sleep. Okay, now narcolepsy had to do with the sleeping thing per se, but cataplexy is very often associated with narcolepsy. It has to do more with the motor mechanism, and the main symptoms involve the sudden muscular weakness triggered by strong emotions such as laughter, anger, and surprise. It's really, really complex, and to this day we did not find a full cure for either narcolepsy or cataplexy. Okay, we could say that for amnesia there are some mechanism or strategies that we can use to address that, minus the loss of neural bioneurological factors due to alcohol consumption. But for narcolepsy and cataplexy, we're still not able to find a definite cure. I even have some colleagues that were affected by severe narcolepsy, and I remember in grad school and medical school, they were able to write all their notes and they will fall asleep, and then they will just wake up a few seconds later, usually less than 30 seconds later, and they will just continue writing notes. And they did this in every lecture, whether we're talking about biology or talking about anatomy, pathophysiology. It was as mesmerizing and intriguing to watch, as well as terrible to experience. I'm still friends with these colleagues of mine, and of course we help each other in grad school. But it's quite intriguing from a scientific perspective, and really empathy inducing when you witness that. Now, the friends of mine that I was able to interact with had a really mild version of narcolepsy, but the two examples that I want to quote here that you can review in the video, one has to do with narcolepsy and cataplexy, and the other one with amnesia. And the first one is D. Dodd, who was a wonderful person and passed away recently, relatively recent, and he suffered from both narcolepsy and cataplexy. He's a British man, and was able to navigate this horrible disease, and really was not able to interact appropriately, because what happened, again, I don't want to spoil the video if you want to watch it, but one of the tragedy of narcolepsy is not only the fact that you are deprived from a conscious state and you cannot really stay awake, alert, and focused for any really long period of time, but also there's a social and emotional dimension to it. First of all, you might be afraid of being happy, because any type of strong emotions, even just laughing, will make you fall asleep and physically fall and hurt yourself. Or you also have a social dimension of stigma and blame, where you might just walk on, downtown, and you just fall asleep and you just crash on the sidewalk, and the average person who might be heartless might think of you as either drunk or drug addict, or all sort of things that are really really terrible to witness on top of the disorder itself. So D. Dodd, it's the person I would like you to watch in the video. The other person from amnesia is Clive Waring, also British. He was working for the BBC radio. He was a musicologist, a very accomplished musicologist. He was also a tenor. He was a piano player and conductor, and he developed chronic anterograde and retrograde amnesia. I think he was born in the late 30s. I don't remember the exact year, but he developed that, I think, in mid 80s. He was accomplished in all these fields with the music, but after that, he lacked the ability to form new memories. So he cannot remember most of the things that you would usually associate with anything beyond strict biographical memory. So he still was able to perform a whole sonata on the piano. So that type of memory, if you remember, we said last week, was not affected. Okay. Again, I don't want to spoil the video. I really want you to watch it. But this has to do with this perception of self. How far can we go? How can we perceive our sense of self if this is happening? So this is something that I would like you to watch, and hopefully you'll be able to reflect upon those videos and relate to these people in a enhanced, empathetic way. One more thing I want to discuss before I let you go is it's a study on mood changes, because consciousness also has to do with the way we perceive ourselves, and we perceive ourselves with perception, sensations, memories, and emotions. So mood is definitely connected. And this is something that I took from the textbook, but again, if you don't have the textbook, it's no problem. It has to do with this study that challenged popular stereotypes about PMS, and in these studies, college women and men recorded moods daily for 70 days without knowing the purpose of the study, which is essential, as we mentioned before in week 1 regarding the blindness aspect of studies. In any case, at the end of the studies, the women thought their moods had been more negative premenstrually than during the rest of the month, as you can see here in the black line. But their daily diaries actually showed otherwise, which is the line in red. Now, both sexes experienced only moderate mood changes overall, but there were no significant difference between women and men at any time of the month. All right, so as you can see here, so I should probably have added here mood. Okay, so this is the mood levels, mood. Okay, this level here. So from negative down here to positive here and neutral here. So you see that in both cases you have this swing, right? This mood swing, the male daily report in green, up and down, so lower moods here, higher mood here. And for the women, pretty much the same. You could say that overall, women reported more positive moods overall than men, okay, but very similar curves, okay, overall in the 70 days. So we don't really know what could have happened in these 70 days, but the studies indicated the retrospective reports appear to indicate that the mood was actually higher and lower with higher peaks. Now, what this study does not mention is that, as we discussed in the context of memory, our current memory might have changed what we previously thought, okay? So it actually, this might have escaped the researchers, but the study could also indicate the opposite, which is we might be more prone to report something while we currently experience that it's not as objectively balanced or, let me say, true as afterwards, right? So this is really interesting because in retrospect, we might thought, okay, actually my mood swings were bigger than they really are. But this does not mean that as we were experiencing that, they were not as big. It simply means that while experiencing that, we might or might not have the propensity to mitigate the effect of these highs and lows. This is not just to do with the mood swing itself, but it's an essential component of psychology, especially in the context of psychotherapy. If you experience something, you might experience something in a non-objective way for the obvious etymological reasons that you're the one experiencing it, so it's subjective, and this does not make it wrong or not wrong or less wrong or true or false. It simply means that it might or might be not fully matching reality. And then, of course, that would apply to men as well. But the retrospective report really are different in comparison to the female retrospective report. So you see these changes here. This is pretty significant, okay? And as well as the law would say, in fact, opposite, okay, look at here in the ovulatory period, how much of a difference when the peak goes down here and goes up here. But a classical example here, it's not only relevant for the way we interpret mood as connected between the nervous system and the endocrine system. And of course, since we're talking about this cycle, it's essential. But even more so if we're talking about how our self-perception might be more or negatively affected by the mood, the current state of affairs, the current state of consciousness we are in. This is the replication in the context of suicidality, for instance, okay? Or things such as manic depressive symptomatologies. I do understand we did not cover psychotherapy, diagnostics, and psychopathologies quite yet in this semester, but it's a great example of how studying consciousness and self-perception, it's not something that can be understood immediately without a very profound and well-balanced theoretical philosophical understanding. Even something so simple as this study can be misconstructed or misinterpreted, or at the very least partially interpreted, where everything we discussed about memory and our conceptualization of self can be also flipped upside down. In conclusion, what I'm trying to say is that this is not the case I'm making, that everything is about personal interpretation. We can toss all of the objectivity of the study in the garbage. Quite the contrary, we still study more, so we have a more complex picture of the study itself. And this will conclude week 6. So thank you very much for your attention. There's a lot to cover this semester, but I hope you were able to navigate the complexity of the topic in a smooth way. As usual, if you have any questions, feel free to email me. Otherwise, on to week 7. Bye-bye.